So it's with great pleasure that we have now the honor of introducing the international lecture that we have had now for some 11 years. And in the last 2 years has been funded by Hank Greenberg and Corinne Greenberg in honor of Peter Guida. Let me just tell you, this is therefore the annual Corinne and Maurice Greenberg International Visiting Professorship in honor of Peter Guida. The Department of Surgery had a long tradition of international lectures. We started in 2008, as you can see from the back of this brochure. And it was done to remind of the importance of international collaboration in medical and surgical education and surgery. And 2 years ago, Hank and Corinne, here depicted, decided to fund this lecture to make sure that we could invite international speakers to come and spend several days with us and be able to cross-pollinate and exchange ideas and experiences. Hank Greenberg wanted to do this in honor of Peter Guida. And here you see a picture of Peter Guida with his wife Bernadette Castro. Peter and Bernadette were good friends of the Greenbergs. As a matter of fact, Peter and Hank flew around the world many, many times, and to a certain extent, Peter was almost the personal physician for Hank Greenberg and the quarterback of any health issues that he had. Peter was a surgeon. He graduated from Albany and then was an intern and a resident in this program, and finished in 1961, and then became a faculty member of this department and specialized in vascular surgery, thoracic surgery, and cardiac surgery. As a matter of fact, Dr. Schneider, I believe that he did the first abdominal aortic aneurysm in this institution, and actually I also believe that he did the first cardiac surgery procedure in this institution. He was one of our esteemed faculty members. He retired in 2004 and continued to be active in the medical center, and actually together with Hank Greenberg, he instituted the Greenberg Award, which is given yearly to one faculty member as the highest recognition of contribution to this medical center. So it is therefore now with great pleasure that we welcome Dr. Leonard Washington Amango to give a grand rounds on global surgery, and for his formal introduction, I'm going to ask Dr. Gallagher to come to the podium.
Good morning, everyone. As Dr. Michelozzi said, this morning we honor the memory of Peter Guida, who was a surgeon here for more than 60 years. In his honor, I present to you our visiting professor, Dr. Leonard Washington Amango. To those who know him well, he goes by Dr. Washington. He was born and raised in a small village in Mara, a region in Tanzania, in October of 1969. In his teen years, he joined a seminary school with the intent on becoming a priest. At the same time, he began working with a Canadian nurse as her assistant, providing primary care to people of his village. After she returned to Canada, he was appointed as the nurse, despite being only a teenager with no formal training. Impacted by this experience, he changed his plan away from the priesthood towards medicine. In 1994, after secondary school and his national military service were complete, he began study at what was then Tanzania's only medical college. During this time, he developed an interest in surgery through working hand in hand with residents. let's see. At the time, Tanzania only had the one medical school, and it was very competitive to enter. But students were eliminated along the way as the years progressed. In 1999, Dr. Washington was only one of 14 of the original 50 students admitted to graduation on time. He then completed a one-year internship at the Bugando Medical Center. In 2001, following his internship, he was appointed director of a district hospital in the rural countryside of northern West Tanzania. He worked as both administrator and clinician, including performing and supervising surgery. During his tenure there, he was awarded a scholarship to Germany to complete a Master's of Business Administration in Health at New Ulm University of Allied Health Sciences. After completing the Master's, he returned and spent a total of 8 years working in the rural district hospital. In 2009, he left to begin specialist training in surgery at the Makerere University in Kampala, Uganda, graduating in 2013. In 2014, he joined Weill Bugando Medical Center as general surgeon, where he works today. During his tenure, he has been deputy chief of surgery, acting director of clinical services, and now chief of surgery. His primary clinical interests are endocrine and breast surgery. However, he practices a broad range of surgery daily. Dr. Washington is an active member of the Tanzanian Medical and Surgical Association and the Tanzanian Christian and Medical Association. Dr. Washington and his wife, Robbie, have 5 children. He loves to read and garden, sing, and often plays piano. He shared with me that his passion for surgery comes from its ability to heal others, especially the disadvantaged ones, so that they can realize their goals in life. Ladies and gentlemen, it is my great honor to welcome Dr. Leonard Washington Amango to the podium.
Thank you very much, Dr. James Gallagher, for that nice introduction. I really feel honored. And I also would like to take this opportunity to thank the all organization on the possibility that I'm welcomed here. When I looked at the brochure, I found that all the members that have been invited so far are from developed countries or high-income countries. And I'm the only one from Africa. This is a great honor. Thank you very much. As Dr. James Gallagher said, I would like to go directly to my presentation or my lecture. And before, the lecture is about the global surgery, as you can see. But before I start talking about the global surgery, I would like to introduce you to where I'm coming from so that you can know what's going on. I'm coming from Tanzania, and Tanzania is one of the East African countries, together with Kenya, Uganda, and so forth. It's a low-income country. And as in the map there, you can see Tanzania. And the largest city of Tanzania is Dar es Salaam, found along Indian Ocean. And the capital city is Dodoma. It's found in the middle of the country. But I'm coming from this place here, since Tanzania is divided into zones, which can be likened with states. And the zone I'm coming from is Lake Zone. It is along Lake Victoria, which is the largest lake in Africa. The city I'm coming from is Mwanza, and it's the second largest city in Tanzania. And from Mwanza to the largest city, Dar es Salaam, is 700 miles. And that would require somebody to travel by public transport 20 hours. And Tanzania, I say I come from the low income, But there are wealthy people who have been able to build a very fancy private hospital, like the one that is found along Indian Ocean, that is just along Barack Obama Road. Okay, but the population of the Tanzanian is 55.6. That is about 1/6 of the United States population. But 70% of these people are living in the rural areas. As you can see, those grass-thatched houses in the mud, houses around there, but the problem of water is still existing. And from what I said, since the majority are poor, they can't afford being treated in those fancy private hospitals. The public hospitals are the ones they are depending on, and therefore it's worthwhile talking about the healthy system of Tanzania. And there are 7 levels of healthy care provision in Tanzania, starting from the least one, which is community health. And in that picture you see, these are the systems that don't have the healthy facility. There is only a community health worker going around the families trying to find out if there are problems. And they refer these patients or these clients to the next level, that is dispensary. And a dispensary is just a simple building, yes, with primary health care, and mainly they do a lot with vaccinations. And they're also giving health education, treating minor issues. But as far as surgery is concerned, they can just do minor stitching if there is injury. But if they fail, they will have to refer this patient to the next level. There are no doctors in there. And the third level is healthy center. The healthy center, there are no physicians, no doctors. They have wards, they can have inpatient services, and they can perform some surgeries. And the critical thing here, or something to mention, is that there is the so-called task sharing. So if there are no doctors who can perform operations, we have assistant physician or physician assistants who have been trained to perform the emergency operations, and this has gave us a lot of fruitful effect. They are, instead of people dying, they can be rescued. And as you can see in the picture, bottom picture, we have some operations going on. But currently, we have the so-called Safe Surgery 2020, and this is funded by the GE Foundation from the United States, and we are very, very glad about that. They are making sure that the WHO checklist is used and these people perform operations in a safe way. And that is the ongoing now. So if at all this fails, they have to refer. But the country is big. How many of these are there? We have got the total number of 586, but only 18% of these can perform surgery. The rest cannot. So that could be in the next phase. We have to strategize this. If they fail, they have to refer the patient to the next level, which is a district hospital. And the district hospital saves about 100,000 to 500,000 people. And the procedures that can be performed are the laparotomy, C-section, or setting an open fracture should be, this should be present. And in other words, we are talking about bellwether procedures. And as you can see in the picture below, we have shortage of staff. Therefore, the relatives have also to join hands in trying to wheel the patients into the care. And these district hospitals, they don't have surgeons, but they have what I said about the task sharing. The MDs that have just graduated from the medical school and finished internship, they are able to perform surgical procedures. Our training is competence-based so that they can work. And in this picture I showed you, I spent my 8 years working here as a director of this hospital, but also performing surgeries. The total number of this kind of hospital in the country is 85. But a good thing is that all of them can perform surgeries. Okay, so if they fail, and that's what I've been doing, they have to send the patients to the next level, which is a regional hospital. And the regional hospital has an MD that went for residency and specialized in certain particular specialty, such as obstetric and gynecology, surgery, or anesthesiology, or they might be physicians, internists. Now, one of them will be the director with leadership skills and surrounded by others. They work together. So the picture I'm showing you is one of the regional hospitals that is found in Mwanza city, and we receive patients from here. And a good thing is that in this hospital, one of the pediatric burn sites were established with collaboration, through collaboration with Weill Cornell. So Dr. Jimmy Gallagher, thank you very much, because he's one of the pioneers of this. And this was established in 2012. Now, how many such hospitals are there within the whole country? We have 28 of them, but only 82% can perform to the level I described, because not all of them have got specialists. Some of them are having just only MD who have not undergone residency program. And each of these hospitals serve from about 500,000 to 3 million people. Now, if they fail, they have to go to the next level. And the next level is a zonal hospital. And there are 5 of these, but I've taken an example of a zonal hospital, is my hospital, Weill Bugando Medical Center, which was built in 1971, and it serves about 20 million people. It's located in Mwanza City, and it has 1,000 beds. I think that is larger, more beds than even Weill Cornell Medical Center, what I learned. And in this hospital, we have 6 operating rooms, but we have started building 7 more. And out of these 7 more, 2 are particular for emergency surgeries. It will be located in the emergency department. And they will be opened in 2019. As you can see in the picture, our main task is training. All zonal hospitals have to train. And we have down there medical students in OR. And for us, medical students have to wear blue and to be differentiated from the senior colleagues. And I was the one performing operation then, instructing the students. Now, before collaboration with Weill Cornell, we never had a medical school. But then, when this began in 2003, we started training medical students. And so far, we have been able to cumulatively graduates over 1,000. And we are so much thankful for that. And we have also increased the admission, the number of the students that we admit. Like this year, we are going to admit more than 200 medical students. And this is going to add up and reduce the scarcity of workmanship in our country. So, ladies and gentlemen, I would like to show you a little movie on our campus. So that is Wild Bugando, as in the entrance as you are going in. And that is the training campus with hostels, student hostels. And that is Mwanza City, and those are students, they are learning. And that is our new CT scan, laboratory, dialysis unit, and that's all. So, if we fail in this kind of hostel, then we have to refer to the national hostel. And there are 7 national hostels within the country. And mostly they save particular diseases. Only 4 will provide surgeries. And as you can see on top, we have that one there is cardiac surgery alone. And the other one that follows here is orthopedic surgery. And the rest can provide general surgery. Now, if you can see, all these hostels are in Dar es Salaam. So other areas have got no possibility. They have to travel there, and it's very expensive for them. So that means we, as Bugando, Wild Bugando, we are striving to make sure that we provide high quality, almost to the standard of the national hostel, to save the people. Now, in Tanzania, we have been working in collaboration with the WHO since then, and we have looked, as you can see, WHO was more concerned with communicable diseases in the past. And we have been working very well on this malaria, HIV, tuberculosis, of course, and Ebola as prevention. Of course, we have never got it in our country. We don't wish to get it. Okay, now, and Tanzania has done very well on this aspect. If you look at the maternal mortality, under 5 mortality, we have been reducing this. And so far, when we started this in 1990, when the Millennium Development Goal was set, up to when it ended in 2015, we had reduced it from 870 deaths per 100,000 people to 432. We never achieved the goal, which was 75%. We reduced it by 47. And the under 5 was also reduced. HIV is also reduced. And thankful to the George W. Bush, the money we received, we spent it on the ARVs to prevent the new infections and all that. And we have been able to reduce it to now 3%. And the outcome of reducing all this, we have been able to raise the life expectancy to 65. I'm very happy because it was very low. Okay. Now, in the 21st century, okay, the role of surgery in human health become clearer because, as you saw in the previous slide, this was more communicable disease. Now, surgery is becoming clearer. What about it? The clear thing is that about 57 million deaths annually do occur from non-communicable diseases, and mostly require surgery for treatment. And another thing that is clear is that this figure far exceeds the 1.83 million people that were dying from malaria, HIV, and tuberculosis combined. So this means surgery is now really, really coming into the agenda. And at least 1/3 of all human disease involves surgery. And to achieve the new WHO Sustainable Development Goals 2030, Healthcare system strengthening and surgical capacity must be included. So, it was time for change in the world's perception of surgery. But few facts were known in the globe, and this called upon the so-called Lancet. What is Lancet? It's a journal with a focus on global health issues. And a Lancet Commission is a group that forms temporarily to address problems and hopes to find solutions that result policy change leading to improvement. So, why commission in a global health surgery? We used to receive, or people used to provide surgical services, or there were many actors without coordination. No mention of surgery on the previous global health agenda, as we saw. And therefore, a group of 25 people, or commissioners, were formed. And of course, with the help of contributors from 110 countries. If you see that map with blue, they all came from the 6 continents. They met and they discussed the issues. And they organized to find out the problems. Actually, they met in Africa, in Freetown. They met in Boston. They met also in Dubai. They discussed all these issues. And they also looked at the extent of the problem. They looked at the frame of the problem, solutions to the problem, and how to monitor the problem in the future. So, what is the results from this? There are 5 key messages, and they set indicators for surgery and the recommendations. Now, what are these messages? 1, 5 billion people do not have access to safe, affordable surgical and obstetric and anesthesia care. And in low middle income country, 9 out of 10 people cannot access basic surgical care. And another clear message is 143 million additional surgical procedures are needed in the low middle income countries. And of the 313 million procedures performed each year, 60% are in the poorest nations, where 1/3 of the world population lives. And 25% of people who do have surgical procedures will have catastrophic health expenditure for seeking health care. The expenditure is the highest in the low middle income country. Within any country, this lands mostly on the poor. And investing in surgery services in low middle income countries is affordable, saves lives, and promotes economic growth. Surgery is indivisible, indispensable, part of the health care. And the healthy aspiration of the Sustainable Development Goal of the WHO will be impossible to achieve without that surgery, anesthesia, and obstetric care that is available, safe, and timely, and affordable. Now, one of the most important findings is the 4th key. That is, investing in surgery services in low middle income countries is affordable, saves life, and promotes economic growth. And the scaling up of surgical care will cost you approximately $450 billion in the whole low and middle income countries. And during the same period, without improving it, US dollar 12.3 trillion will be lost in the GDP, the overall GDP of the world. And the failure to improve surgical care causes -2 on the GDP growth. And instead of thinking development assistance for health, that has been so since then, we should start thinking funding for surgery as healthy assistance for development. I think that sounds good. Absence of surgical care is partly responsible for slowing prosperity in the nations. And if you look at these indicators, the current indicators in the WHO and others to track global disease like indicators for the surgery. These indicators here, you see the aspect of the surgery is very low when you look at the frequencies. It's very low as compared to that of the medical, as you can see. Look at this. Nobody reports. 0, 0, 0, 0. It's very funny. Now, the Lancet Commission came up with the 6th indicator of surgery to track progress. And this includes access to essential surgery within 2 hours. This is going to be possible because of the numbers I showed you of those health facilities. We have also the number of the surgical obstetric and anesthesia healthcare professions per 100,000 people. The goal is 20. And number of cases per 100,000, the goal is 5,000. And the number of deaths following surgery per number of cases done, this is actually perioperative death, those who die before they're discharged. And we also have these two, which addresses the financial aspect, the catastrophic expenditure and the impoverishment expenditure. Now, in Tanzania, if you look at those goals, if you take the second indicator, the goal is 20, but we have done on, the goal is 20, but we are at this level here, 0.46. Look at that, per 100,000. And so we have a hell of a mountain to climb. And the other third indicator is 5,000. That is the target, and we are at this level here. The other 5th, 5th, and the 6th indicators are to try to prevent the catastrophic expenditure, and the other, you find that for the impoverished, we are at this area here. The goal is 0. And for the catastrophic expenditure, we are at this level, and the goal is 0. Okay, now, this Lancet Commission had more than 100 concrete recommendations for making progress in each of the 4 domains for nations and international stakeholders to work together. And they are like, these 4 include healthy system delivery, work of training and education, economics and the financing, information management. And these have got things in it. And if I take an example of the work for training and education, this calls upon training more human resource. You can also convert it by task sharing, as we are doing in Tanzania. And there is also putting some regulations in this and others. Now, if you look at this calls upon the so-called collaboration. To achieve the goals of the Lancet Commission on Global Surgery report, we must work together as never before. And we have to collaborate with the funding agencies, the concerned nations, or the community of surgery. All these have to come together and collaborate to achieve that. And what must take, now who must take the step? Who should start this? It's the nation involved. We must act first to become the change agent for the surgery. Now, the Lancet Commission on Global Surgery is gone, but the network remains. The Harvard Medical School program in global surgery is working with the nations to make their national surgical obstetric anesthesia plan. 3 are complete so far. You know, there are so many low-income countries, low and middle-income countries, but only 3 have done this, have responded to the Lancet Commission recommendations. And these are Ethiopia, number 1, Zambia, number 2, and I'm glad to say Tanzania is number 3. Of course, number 4 will come. It's on the way. It's Nigeria. Now, what about this? Tanzania has made the National Surgical Obstetric and Anesthesia Plan and is looking forward and is trying to move towards this. How have we done this? We have committed to increase our healthy budget from 9.1% to 10% of the total budget of the country. And actually, in Abuja declaration, it was needed that all African countries should have to increase their budget to 11% of the total budget, annual budget of the country. But Tanzania is moving towards that. We are only with 1%. We'll reach there soon. Okay, now we have also developed the vision. How can we move towards this? We have a vision that says Tanzanians live a healthy and productive life. And by 2025, we have committed ourselves to provide safe, affordable, and timely surgical anesthesia and obstetric services for all Tanzanians. Now, this is our president, Dr. John Pombe Magufuli, is the current president, was elected in 2015. And since his election, he's determined that he has to move Tanzanians from low-income countries into middle-income countries by 2025. His 10 years duration, he has committed himself to do that, and he has started. He's the man of no nonsense when it comes to corruption. He's trying to help us in that. Now, the American Community of Surgery is also involved in recognition of the Lancet Commission for Global Surgery 2030. As you know, the consortium of the academic global surgery. This is led by Girma Tefara, MD, is the director of American College of Surgeons. Actually, they didn't keep quiet when this came out. They also sat and tried to find out, what is this? What can we do about it? Is it real? So they also set a vision, and they said they are envisioning unifying academic programs to discover solutions for safe, effective, and affordable surgical care worldwide. And the mission is to reduce the burden of untreated surgical diseases worldwide. We collaborate to cultivate the next generation of compassionate, capable of global surgery leaders experienced in education, research, policy, and advocacy. Now, pause, recognize the shift in global surgery. I have to admit that American Surgical Association is one of the prestigious and the powerful associations in the world. We also have ours, but we respect this one. They didn't keep quiet. They also look at this. They had said, and in the journal that is yet to be published, they came up with this. In the past, US surgeons' efforts in the low-middle income were mostly focused on the direct provisions of the care, ranging from short term, like weeks, months, or years, or decades. But they now, this is exemplified by what was happening. They say this is important, they can't stop it. Like in Kenya, which is also found in East Africa, 40-60% of all surgery in Kenya is performed in faith-based missions and style centers by foreign surgeons. I also admit, even in our cardiac institute, we receive surgeons from America coming to help us to transfer knowledge. Yeah, that is good. But what should change? These efforts are critical going forward, but we must ensure that this clinical care is in support of the National Surgical Obstetric and Anesthesia Program of the host nation. So they agree that they should continue doing that, but probably in another perspective. And progress will require longer-term activities not yet underway, involving wider organizational arrangements not yet in existence, based on the needs, resource, interest, and the priorities of the nation involved. Now, what must we do together? Because this calls collaborations. What must we do together? I take pride in the principles and wisdom of our leader partners. There are people who are visionaries. They saw this kind of partnership to improve health earlier. This is Sandy and John Weil. They knew then to improve health care for humanity, academic partnership would be important. And therefore, from 2003, they signed a memorandum of understanding with Bugando, because it was Bugando Medical Center, and it turned to Weil Bugando. And from that, we have been able to have certain programs concerning training that has brought benefits to the country. But through this collaboration, we had Rob Peck, who is now associate professor in medicine, has been stationed to work in Wild Bugando and the Catholic University of Health and Allied Sciences for the past 15 years, full time. He has done a lot in clinical services, education, and research programs. And just to mention, many people have been doing very well in internal medicine. We are lacking this in surgery. I hope we'll have another PEC, surgical PEC, in our setup. Okay, so there are some other programs going on with the Weill Cornell. We have Masters of Science in Clinical Epidemiology, so our people can also have this. And there are also scholarships and mentorship for PhD going on. And just to mention, since we started in 2009, we have been able to have 43 internal medicine specialists from Catholic University of Health and Allied Sciences, and 31 pediatric specialists, 50 obstetricians, and 28 general surgeons. So we are lagging behind even that statistics. And I would like to mention something that even in surgical aspects, we have been having collaborations. In Tanzania, we have been collaborating with the Weill Cornell Medical Center in the aspect of burns. And this, if you look at this, we have Dr. James Gallagher there with other collaborators in our setup. We have 2 burn units, one in the regional hospital I mentioned, and the other in Weill Cornell Weill Bugando Medical Center. And we are doing wonderful work. We are preventing complications. The nursing care has improved. And this has been there for 7 years. And the 2 burn units, as I said, have been formulated. And their next visit is going to be next year in February. Now, another one to mention is ophthalmology. We still have also collaboration with our good friend, Leonard. He has done a wonderful work there. He's mentoring 2 ophthalmologists who are very young and very ambitious. And next year, we are going to dedicate 1 operating room from the 7 we are building just for ophthalmology. Hopefully, we'll be able to equip them. But we said that is nothing. We start with the construction. Okay, now, it is important to consider motivation of all stakeholders needed for success. So American Surgeons Association came up with analysis on how the Americans would benefit from these collaborations. Should they sit down and say, oh no, the commission came up with this, it doesn't concern us, we are not the low middle income country. They said, no, this collaboration is beneficial for all of us. In general, there should be benefits. The benefits to the faculty will be like things like to realize their humanitarian passion, perspectives for research, limit clinical burnout. You can get clinical burnout, and when you come there, you get a little bit of relief. Innovation, and so forth. Now, for trainees, I mean residents and medical students, there would be things like to develop trainees' humanitarian values. But something very important to mention, there are diseases that are seen in our setup that are not found here. You will improve your knowledge on that. And the way people come here when they have tumor, it's at a preliminary stage. For us, it's very huge. And you find, what are we going to do with this? And you can improve your knowledge on that. And your clinical judgment could also improve. And for departments of institutions, can have things like recruiting tools or institutional branding and a global presence. So there are benefits out there. Ladies and gentlemen, I'm concluding. The slide that you see is not taken from anywhere else. This is taken from Tanzania. Somebody on the plane took the sunrise from Mount Kilimanjaro. That is the highest mountain in Africa. And I have these words: umoja ni nguvu, utengano ni udhaifu. What does that mean? This is a Swahili proverb that says, together in unity we are strong, but isolation is weakness. I've been talking about collaboration. I have seen Americans stepping when certain countries are fighting. Why don't they sit saying it's none of a business? And I was transferring this to surgical, global surgery. Things that are happening there which can change the world. It is time that we collaborate and stick together to make changes in surgery. We have things. We are doing great towards the achievement of the goals. We are setting facilities. We are training workman force. We are struggling with the supplies and everything. We can look at where we can step in. But I assure you, we have been receiving students from Germany. They are testifying that they are changing their mind when they see how we can use little resource to bring changes in people's health. They are learning that. I've been receiving exchange program residents in internal medicine. We see them there, not in surgery. I really feel that. I appeal to you. We are ready to exchange this too. Now with this one, I would like to say, Karibu Tanzania. That means you are all welcome to Tanzania. Thank you very much.
Thank you, Dr. Washington, for that inspiring lecture. Would you be willing to take questions?
Of course, yes.
Dr. Washington, thank you very much for this very inspiring lecture, really stating the current situation in Tanzania and most importantly the vision for the future and the powerful message that you've given to all of us in terms of global surgery and the importance of participating to that. One of our previous residents, Katrina Mitchell, spent a total of, I think, about 2 or 3 years. And she really helped us understand what you were trying to do. But today's lecture was even more powerful. So thank you very much.
Thank you.
So in the current situation, let's assume that a patient in the Lake District, away from your hospital,
Yes.
has a large lump in the breast. And you and I know that probably that is a cancer. This particular patient has to go through the different steps, or can it be directly referred to your hospital? And how long would that take?
Should I take more or I just answer directly?
One at a time, Mr.
Okay, one at a time, thank you. As I said, the referral system is like I showed. So in the village, because we are serving over 20 million people living around Lake Zone, so the first people to recognize this patient probably would be a village health worker, because he or she is trained on this kind of things, screening and all that. So when they find a breast lump, they say, oh, this is a danger sign. It might be cancer. So please, you go to the health care where they can provide services. They will not bother this person to go to the health center. They will not bother this person to go to the others. This kind of diseases that are not provided at any level below will come direct so that we don't waste time. They'll come direct and they will never say, you don't have the letter from regional hospital, you go back. We'll receive this patient because, for instance, in our hospital, we have got nowadays, we have built the cancer institute, the cancer unit. So in surgery, we'll receive this patient and work on this patient, preliminary investigations, including ultrasound-guided biopsy and all that. And then, after diagnosing the patient, we'll work with the Cancer Institute to treat this patient. Initially, there was only Cancer Institute, one Cancer Institute in the whole nation, in Dar es Salaam. But right now, we are thankful that we have built ours, and we will treat that patient in Lexon. Thank you very much. Yes?
Thank you, Dr. Washington. That was a great talk. One thing that wasn't mentioned, and I can't remember if it actually was talked about in the Lancet Commission, but you talk about workforce.
Yes.
And one of the issues that's always been is brain drain. You train your doctors, but then those doctors go and leave the country. And so you've put in all the effort, all the expenses to train these surgeons, but then they go to Germany, they go to Europe, they go to America. What steps have been recommended by other governing bodies, such as the Lancet Commission or the WHO, and what steps specifically is Tanzania doing to prevent that, since you now are improving your training programs?
Thank you very much. I would like to say this is there. And it's sad to say we had a very prestigious anesthesiologist trained in Israel, came to our hospital to work in cardiac surgery, and left. And we were crying out there. We asked him, why did you leave? I'm looking for green pasture. So that will always be there. And it has been addressed that it's not only training, strategies to retain them has to be there. And our good doctors are moving to Botswana, which is a middle-income country, lower middle. And the Botswanas are going to South Africa. South Africans to UK to United States, and all that. It has always been there. So in Tanzania, we came up with strategies. We are going to have motivational strategies to retain these people. One of them is continuing medical education. There will be a clear path that if you work here for 1 or 2 years, you can be given scholarship. And you sign contract that if I come back, I will have to work here for not less than 3 years or 5 years. And that is a strategy that is in place. But the effect of brain drain is so much. And that's why in Tanzania, we have also come up with task sharing. If we give those people opportunity to operate, the ones that are not needed in America, they will stay. Because they can do the function or the work, but nobody is going to accept them in America because they don't fit in that system. They fit in our system. Yes?
I wanted to share something you taught me, which I think is very powerful about what Tanzania changed in 2015. For Tanzanian citizens who are 18 years or less, they can purchase healthcare coverage for $25 US per year, which is affordable. And so what a healthcare system needs to prevent brain drain basically is salaries, among other things. And so if you actually enable a system whereby your population has coverage, whereby when they use it, the doctors and the nurses, there's money for consumables and salaries. So to me, this change in 2015 in Tanzania is really remarkable to try and sort of lift the healthcare system from the financial perspective so that the money flows into it for the staff?
Thank you very much, Dr. Jimmy, to remind me about that. It is really frustrating when you work in a facility with no consumables, just because you can't buy them. Even if they pay you well, you will leave. But the government has come up with this, which is alternative financing, healthy financing, and it has worked. So in addition to your normal salary that you get at the end of the month, then when you work on this patient, there is reimbursement from insurance. Currently, we have only 19% of the people insured, but we are determined to go above 50% by 2025. And one of it is what Dr. Jimmy said. All children, if you have a child, we have got also people from America just paying for certain children. You say, oh, it's only 25. I can pay for 3 or 4 children for 10 years. And the number of children who are insured have been increasing. This also involves the students in secondary schools and primary schools.
Well, congratulations. That was a phenomenal presentation. You've done wonderful work in Tanzania with surgical services. For the past about 16 years, I've had the honor of working with surgeons in Ghana and Ethiopia in breast cancer projects, and hopefully we'll be able to extend those collaborations to work with you as well. But my colleagues in Ghana and Ethiopia often complain that a lot of their late-stage distribution for breast cancer is because of women dealing with herbal medicine providers, and they don't get to see the trained healthcare workers. Do you still deal with that challenge? And if not, how did you get past it?
We have got an association called the Tanzania Tanzania Medical Women Association. And they have done very well with this. They have gone throughout the country to educate people that if you see anything, and self-breast examination has been so much advocated out there. So the issue of the herb is there, yes, but they have been told if you come to the hospital and they can't offer anything to you, then you can revert to the herbal. But don't revert to herbal before coming to seek help. So they have been going to the villages, and the village health workers have been trained also to educate those people. So it's a challenge, but they have been trained to educate, and it has been going lower and lower. Many women sometimes nowadays are coming to just say, oh, I heard this on the TV, I want to check my breast, I'm sorry, can you do mammography? And say, yes, of course, we can do it here, but it's only in this level, you see. So it's a challenge, but has been addressed.
Wonderful.
Thank you.
Yes. Excellent presentation. Thank you very much. My name is Quincy. I'm from Gabon. A trend that we've seen in many low and middle income countries has been what we call the double burden of disease.
Yeah.
We have all the diseases and the bellwether procedures that we need and that we can't provide. But on top of that, our population also now starts suffering more and more with oncological issues, diabetes, and truly long-term chronic conditions. How has your surgical volume and the type of operations your hospital has needed to provide changed based on that trend in the last couple of years?
I do agree with you. We didn't do much effort on the non-communicable diseases, diabetes, and diseases that are resulting from hypertension and all this. This was not the agenda. We used to see intestinal obstructions and all this other. But I agree with you. Recently, we have seen a lot of the diabetic ulcer, foot ulcers. We have seen a lot of just gangrenes, like what we saw here because of the atherosclerotics and vascular diseases. They are on the rise, and we are prepared to deal with this, and we are working in that. Our nation has also changed their perspective on this. They know that the non-communicable disease is also on the agenda, but just like what we usually do, we focus more on the prevention. So when they come, for example, if you come to our clinic, we also start by giving health education so that we do secondary prevention, yes, but they can also deliver this back home there that, we have been told if you want to primarily prevent this, you should not go for this. And unfortunately, in our setup, we don't have all the specialities. Like I saw, it was marvelous here about the vascular surgeon doing all that in the intervention. That patient would have undergone amputation in some of our setups because we don't have all other trained personnel on that. But fortunately, our national hospital has now gone into the capacity of that because our president is trying to reduce the costs of sending people abroad. Instead, they want to bring people, to train people within, and to be able to perform such surgeries, and is committed to provide necessary equipment and facilities that can enable us to do the work. And I think if you follow the news, you will find that we had presidents whose daughters are coming to deliver in the United States when they're pregnant. That means they don't trust their own national hospitals. They don't trust their own zonal hospitals, and that is very funny. But our president currently is the president who would like himself to be treated in our setup. And therefore, he will not be just there to see that he's treated in poor condition. He's make sure that he provides all the necessary safe equipment and the supplies for these hospitals. So that's where he calls upon collaboration too, to help us change things, instead of having a country where people don't rely on their own healthy system. Yeah.
Dr. Walker, thank you very much. Dr. Walker is going to be with us for several days. So I invite all the residents and all the faculty members who may be interested in a meeting with them to coordinate a meeting through the office of Dr. Gallagher. And
I just wanted to mention he will also be, he's staying with us till the end of October. He'll be at the ACS.
Thank you very much.